So for folks who might be new here, I'm JD Olette. I'm the Director of Lived Experience here at Equip, and this is our Thursday Family Support Group. Today I have with me Dr. Megan Hellner, who is our the Director of Nutrition Research, and Maris Degener, who is our Peer Mentor Director. And so we'll dive into some conversation about exercise in a moment, but just for folks who may be attending for the first time, you are always welcome to raise your little Zoom hand, your digital hand there, and pop off and come on and have a direct conversation exchange with any one of us at any time. We also have the chat box and the Q&A, so I get better every week at scanning the chats, scanning the Q&A, and getting those questions out there. So just want to make sure that everyone gets your questions answered, sort of no matter where you are in this process at all. So thanks again for being here today, and I think we'll just get right to this really important topic. That I'm just going to preface this by saying that I met Megan when we started developing protocols and things for Equip about 2.5 years ago, and our experience with exercise and reintroducing it had been a decade ago when my daughter was sick. And so I've learned a lot from Megan, like so much, and I've learned how much things have changed. So I think here on this call, we're going to have people sort of at different places and perspectives, and ours was sort of like clean break from exercise for sort of a substantial period of time, a very long time to any sort of gym workout, that sort of thing. Megan's here with all the latest research and decades of experience in working with patients on this, and a real passion for this particular topic of exercise. And Maris is here with her lived experience on how exercise played a role and the timing, all of that in her recovery. So we're gonna just jump right in. I think Megan has a few slides to get us started.
Yeah. And just a little bit of a background too. I created way too many slides that are beyond the scope of today's chat. And I will not go through all of them, but please don't hesitate to jump in with questions, challenges, any kind of discussion. I would really love to hear from you, because I do think the lived experience voice is missing from this topic in the literature and just in the eating disorder space in general. So it'd be really important to me to hear from you as well. I got into this sort of accidentally, working with eating disorders. You can't help but work with active folks and athletes, whether they're recreational athletes or weekend warriors or exercising compulsively. And then my doctoral work had nothing at all to do with eating disorders. And it was a public health program, and they really emphasized the therapeutic benefits of exercise. And what became pretty interesting to me was that folks with eating disorders struggle with a lot of the comorbidities that can be treated somewhat successfully with lifestyle interventions like physical activity, but that's obviously really complicated in the setting of an eating disorder and someone that has really struggled with abusing exercise, right? So how to kind of merge these two safely became just something I was really passionate about. And could it be done? How can it be done, et cetera? So I will just jump into the sharing of a few slides here. Let me first make sure that I'm in the right place. And if you don't mind, JD and Maris, let me know if I've done this correctly. I seem to have issues with slide sharing. Is that okay?
It's good.
Oh, I'm so glad. So I know this looks like a really long presentation, and I will, are you all able to see kind of like the chat or questions that pop up?
Yeah, I'll feed you the questions in the chat.
Okay. Yeah. Feel free again not to hold off until the end, and please just to fire away. I just want to be able to talk a little bit about kind of current thoughts and practices around inclusion or reintroduction of exercise or physical activity over the course of someone's eating disorder journey or treatment journey. So some of the themes that we'll be touching on, we can talk briefly about so many names for this, but like healthy versus unhealthy exercise, or you'll hear it maybe referred to as therapeutic exercise. And then dysfunctional exercise can be compulsive, compensatory, excessive, many maladaptive. I've heard many names for that all mean something similar in the eating disorder space. We'll talk through some of the benefits of physical activity and how that can pertain to our population, and then some of the dangers of excessive physical activity or overtraining and how we're thinking about that a little bit differently now. And then we can talk a little bit about treatment approaches to reintroduction of exercise, specifically EQIP's approach. And I want to make sure, most importantly, that I address some common, very real and valid fears and misconceptions on this topic. So just a few defining of terms. You'll hear me use the words exercise, movement, physical activity interchangeably, which I think is absolutely fine to do. Again, in the eating disorder space, they're usually and often used interchangeably, but you all may have heard the term joyful movement, which means something slightly different. So I just wanted to give a little bit of a, these terms do mean different things in the exercise phys world. So I just thought it might be helpful to talk through that. Movement would just be any movement, any musculoskeletal movement. Physical activity is a little bit more deliberate. That's any movement of the body or limbs. Exercise is, as it sounds, kind of planned, deliberate, structured, repetitive, done with a goal of improving or maintaining fitness. And then fitness is that set of attributes as a whole that relate to someone's ability to perform a special task. So what do we mean when we say like healthy exercise, healthy relationship with exercise? So I think of someone who approaches exercise with flexibility and who is able to adapt in the moment without adhering to a really rigid regimen. I think of someone who's able to honor the body's need for rest, warming up, cooling down, that sort of thing, but also just taking days to heal, to rest, to relax without a lot of distress. I think of this as engaging in activity or movement that's fun and enjoyable most of the time. And I put that disclaimer most of the time because for those of you that have ever trained for a sport, it's not always super fun to go to practice, but we might do it anyway. Hopefully not when we're injured or ill, but you get the drift. And the motivation is different, right? For someone with a healthy relationship with activity. The motivation might be to improve our mental well-being, to help with some sleep issues we're having, to challenge and celebrate the body's capabilities. That's always really exciting to see what our bodies can do under unusual stressors or circumstances. It's a way to join with others, to make friends and find community. JD and I were just talking before this about a morning walk that she takes with a friend and how just what a nice start to the day that can be versus the kind of exercise that's militant and isolating, right? The motivation is self-care versus self-punishment. That's also very important. Oh, sorry about that. That last slide was out of order there. If we think about dysfunctional or compulsive or compensatory exercise, this is something that we see in most eating disorder subtypes and across all of the eating disorder subtypes, not just in anorexia, not just in bulimia, very, very common. I would describe this as rigid, compulsive, or feeling obligatory, and it interferes with other activities. Maybe it occurs at an inappropriate time or setting. I'm thinking back to a patient that I once saw who was running in the middle of the night in unsafe places and very, very far from home. So, you know, that in itself was a little bit of a red flag. Exercising despite injury or illness. So you have a stress fracture and you're continuing to run on it, or you've injured your shoulder and you're still swimming. Having intense distress when you're not able to exercise, and that's not so much being bummed out that you can't go on the morning walk, but really not being able to tolerate that rest or that time that you need for healing. Another kind of a marker of dysfunctional exercise might be that it's kind of entangled with diet intake, nutrition, eating, food choices, right? So it's not uncommon to have maybe dinner, lunch, breakfast, and eat something that might be out of the norm. And you hear someone say, well, now I'm going to have to exercise that off. It's that compensatory thinking of, I need to earn this food versus these are two, divorcing those concepts, right? These are two things we do that both have benefits and different attributes, and they shouldn't be entangled with one another. And when they do get really entangled, we can think of this as almost a means of purging, right? Having to earn food is something we really want to try and move away from, especially in the eating disorder treatment realm. I see there's a question, so I'll pause there. I don't want to go on for too long without checking in. Oh, I guess I can look at it.
I muted. I was going to say, no, go ahead and finish this because I'll just work it in where it's a good place. This is good.
Oh, great. Okay. Okay. And this one I just threw in there last minute for fun, validated by excessive social media posting. I don't know if there's ever been any research done on this, but I would just guess that folks that tend to feel the need to get a lot of validation for exercise on social media might not be finding a lot of joy in that activity. So thinking of things that don't require that kind of validation come to mind as something that might be a little bit more life-giving and more joyful. I mean, otherwise put, I think of that as a little bit of red flag sometimes for compulsive or compensatory exercise. Might not always be the case, but. So why do people have sometimes a little bit of a dysfunctional relationship with exercise? We go back to the motivation really, and motivations for moving are mixed and complicated. For folks that struggle with disordered eating in particular, oftentimes the number one or primary motivation is to make some changes to weight or shape, weight loss motivated, or maybe it's to achieve a certain aesthetic, right? It can also influence our feelings of self-worth. And what makes this especially difficult is that you won't really meet a healthcare provider that doesn't sing the praises of exercise. I mean, I can include myself in some circles in that category. I get really excited about the therapeutic benefits, but we have to also consider safety first, especially when we're recovering from an eating disorder. I love this little what's this called? I don't know, picture here that was developed by a friend and colleague of mine and ours in the eating disorder space named Dr. Brian Cook. And it just shows how exercise can both, drive social connection and isolate someone, right? It can kind of do both of those things, sometimes depending on the type of activity we're participating in or our motivations. You can be doing this again as a means of self-care or self-punishment. So it's really so complicated, and there isn't one driving force for, why we move. Is this a good place to pause?
Sure. Yeah. So this question was really specific on early treatment, the difference between talking about exercise or activity, like how that process is in early treatment.
Ah, good. Okay. And when you mean in perhaps in front of someone that's struggling?
Right. Yeah. With the person with the eating disorder.
Mainly.
Yeah.
So yeah, we've thought and talked about this a lot. I think even you and I and Maris and I over the last couple of years, because we really like that paradigm of like movement or joyful movement. I think that's a nice way to talk about moving the body in the earlier phases of treatment, or even physical activity to some degree. Might be just fine. In the earlier phase of treatment, oftentimes exercise is restricted, right? Or movement is restricted. So we want to try and help someone think about activity or movement differently. The caveat there is athletes or folks that are training competitively. I think it's really nice to also introduce the idea of joyful movement to athletes, just knowing that it may not land or resonate as well with folks that are actively training or competing. And I found I like to use language that they're using, that they're going to hear again and again when they discharge from treatment and go back to training, talking about exercise, talking about training and strength gains and things like that, just because it's kind of familiar to them.
We definitely, and Maris, feel free to jump in on that as well. For us, we definitely went to the talking about activity, and really our thing for quite a long time in the beginning was that sort of that any kind of exercisey thing was done in the context of like a social thing. Like, so it would be like, we might take a hike as a family, which is like more of an activity than us going to exercise, or surfing with friends that's a fun social activity. That's not exercise. So that was the helpful nuance for us.
Yes. Yeah. Activity sounds more fun. That's for sure.
Yeah. I think that resonates with how my family approached it as well, JD, that exercise just had this really rigid and strict connotation to it for me and for the eating disorder. And I think activity felt a lot broader. Like you said, JD, it could be family get-togethers, things like that.
Yeah, I completely agree. I like the feel of activity, and just the use of those words or movement can be just freeing and life-giving, especially in the earlier phases of treatment. And that might be something to consider, or even just continuing to use that from that point on, because you're right, exercise does for a lot of people kind of have this very rigid militant feel to it. And, you might think of someone like on a treadmill at the gym exercising, but when they're surfing with friends, they're playing, they're having fun, it's joyful, it's different. So
I
absolutely.
think that I just want to put a quick pin in that, what you just said, playful. I think that, I think I'm probably preaching to the choir here in terms of everybody being on board with this, but I think that's something we see happening now. And you have little kids, and so you're going to see this, right? This drive, even in small children, to take play away and replace it with exercise and to quantify the movement and all those sorts of things. That's really, I think, pretty distressing.
Yes. Yeah, absolutely. And it may be that at first some of these terms don't land with your kiddo or with the person that's struggling, but I do think it's nice to keep bringing them up and introducing them to the idea that exercise doesn't have to be or movement doesn't have to be kind of punishing or inflexible, that kind of thing. I think there might be another.
Yeah, so there now we're definitely getting into some pretty specific questions. So you let me know if you have a few more things you want to run through, or if you want to just take questions as they come.
This,
Uh, yeah,
oh,
kids
wow.
version of a Peloton. Um,
Gosh.
so this question, and it might actually feed into what you're about to talk about. What are your thoughts about running as a motivator for recovery? She discovered running after, it sounds like, starting recovery, and finds it helps her feel empowered in her body, however, not yet weight restored.
Please, yeah, that is a very important question, and let's pause on that because I'm going to get specifically to that in not long from now. I want to specifically talk about running and when and how to reintroduce, if that's okay. That's a very good question. Okay, so when we think about safety first, prioritizing safety first, especially over the course of treatment, we also want to talk a little bit about some of the dangers that come with overtraining or overtraining syndrome, which basically means you're not able to keep up with the demands of moving or training the body with sufficient intake, right? We're not able to eat enough to meet the demands of meet our energy expenditure. And I think when people think of overtraining, they think of endurance athletes. They think of folks that are running for hours a day or weight training for hours a day. But for someone that's not able to keep up with even just their baseline needs, walking the dog for 20 minutes or maybe something a little bit more than that can be considered overtraining and dangerous and present some of the same consequences as someone who's exercising more intensely and for longer. So some of you might remember the female athlete triad, which has been around, gosh, I think since the 80s, if not before that. The concept might have been introduced before that, but that was our way to kind of describe this cluster of symptoms that you saw in folks, females who were kind of struggling with disordered eating, not eating enough to meet the demands of sport, irregular periods or the complete lack of a period, absence of a period, and then low bone density, osteopenia or osteoporosis. So those things, when they were coming together, they were called the female athlete triad. But we started to see that as a little bit problematic as the years have gone on, because one, it's limited to menstruating females. So not super inclusive and not, well, I'll get into the why in a minute here, but this newer concept came along a couple of years ago called relative energy deficiency in sport. And this is, think of this as the new kind of 2.0 and more inclusive version of the female athlete triad. Not a triad, as you see here. This is the limited nature of the triad here, but more so this here you can see all of the consequences to physical health and development that come from underfeeding and overtraining. And again, this is not only in athletes or competitive athletes, this is in active persons who aren't feeding themselves adequately.
Megan, I just want to let some space for that to just really clearly hit everyone really hard, that you're very explicitly saying that this happens to people who aren't athletes, and that is very much dependent on your nutritional state, your body state, all of those sorts of things. So you can look perfectly fine or feel like it's fine to be doing these things. Even as you said, for some people, 20-minute walk could be too much.
Yeah, absolutely. It was like years ago, I remember working with a kiddo who was kind of exercising against advice, if we want to put it that way, for 30 minutes a day, something like that. And the rationalization was, my dad's a Navy SEAL and he trains all day long. The difference is that dad is willing and able to meet his needs, to meet the demands of training, right? And it was part of his job. But that aside, that was a big difference. So for her, what she was doing was overtraining, and she was suffering consequences that her dad, for example, was not, right? So I think of this as definitely not just a model for athletes, but for active persons. These are things to keep in mind. And for those, so sometimes folks in the throes of an eating disorder aren't super concerned about the long-term physical risks. So here we see some of the more immediate consequences as far as mood and performance. So one of the hallmarks of overtraining and underfeeding is that you don't see performance getting better, right? You don't see running getting easier, or they're not getting stronger. They're not getting more muscular typically. Performance is actually getting worse. Endurance is suffering. It's a real struggle to get through these bouts of activity. Yet they'll usually push through. And that's, something we work on in treatment, is really listening to the body. Okay, so now probably the part that's more of interest and relevance for the folks on this call here. How is exercise managed in treatment? When I started in eating disorders quite a while ago, the mantra was really full abstinence, and abstinence as long as possible. And the logic made sense, right? It had been regarded as a very serious behavior, eating disorder motivated, if you will. So the idea at the time was to really hold off as long as we could before reintroducing exercise. And it wasn't something that we usually tested in eating disorder settings. There may be an allowance for light walks, some kind of restorative yoga, some meditation, but not really movement beyond that. I think one of the things that I started to struggle with as an outpatient provider after working in residential settings and really buying into the abstinence model was that then folks were discharging from higher levels of care, coming to me, starting to go back to the gym, or maybe they've already done so, and they haven't worked through that relationship with exercise at all. They have no idea how to manage those urges or impulses, and then they're really struggling. And perhaps they've exhausted all of their means in terms of going to higher level of care, right? So that was a pretty scary place to be for that person who had really done a lot of work on their recovery prior to getting to outpatient. So this is one of the things that got me thinking a lot about how to take a low and slow approach to bringing this into treatment at higher levels of care. And another reason, oftentimes in those settings, you don't get a lot of folks that are super excited to report some of their urges around exercise, or some of their kind of disordered thoughts around eating and exercise, because there's fear that just mentioning these urges will step them back. So maybe they were granted permission to walk 20 minutes a day, 4 times a week, and now they report some urges and those privileges are taken away. I don't know that that's the best way to approach this in terms of just kind of helping someone work through these urges. And another reason, in family-based treatment settings, parents, rightfully so, are super afraid of reintroducing activity or advancing activity for a number of reasons. But what does the research say? We do have some research on this. It's not, it's relatively new, and it's relatively sparse, as this says. So when we look at like how to walk that line of prioritizing safety and rest for someone who's struggling with an eating disorder, and reintroducing a behavior that has a lot of therapeutic benefits to it, the research is pretty minimal. What we have found out is that this is kind of to the question on running, psychological factors, meaning someone's kind of beliefs and attitudes around exercise, their relationship with exercise, seem to be more influential and predictive of relapse than the type of activity performed. So it's not just that someone's a runner per se. It's the way that they may be thinking about running in terms of its role in compensating for the food that they eat. That's one example. So that was kind of new and exciting, and something that was kind of uncovered just a couple of years ago. We also know from preliminary research, early research, that activity in treatment can be not just safe, but also helpful. It can help treatment outcomes as long as safety is prioritized and family and patient are able to meet their nutritional needs or the demands of activity as they go along. That's really important. A lot of work has to be done by the whole team, including the family, on helping to shift those attitudes and beliefs around food. And what that may mean for the family is kind of redefining their relationship with exercise and how they talk about activity or movement. Should I pause there, JD, for any reason?
You know what? Why don't you do this slide, and then I think it'll be a good conversation place for us all to jump in.
Yeah. So how are we managing this at Equip? We have the blessing from senior leadership to be fairly progressive here and kind of test new interventions and new ways of thinking about treatment. And that's been really, really exciting. So, obviously we provide virtual treatment, and it's family-based treatment. So we know that it takes an entire village to help someone heal from an eating disorder. This means the team, the family, and in the case of an athlete in particular, that includes their coaches, training staff, etc. And it requires a lot of effort and kind of nuance to properly fuel. That means not only meeting the demands of refeeding, which can be significant. We often have folks whose needs are in the 3,000s, 4,000s, 5,000 calories per day. And that's without the addition of exercise. So is someone able to meet those demands alone, let alone the demands of exercise? It's not enough to model intake after peers. I can't count the number of times I've said that to athletes in particular, even high school athletes who get out of treatment. Of course, they just want to be normal and eat like their peers, but perhaps their peers don't eat breakfast, or they have a banana for breakfast. They go train for their sport, they go to school, normal lunch, maybe a normal quote unquote dinner. But for folks that are in recovery or going through treatment, their needs are high and unable to be compared to those of their peers. So I often kind of take them back to like, what do we know about your body's needs and what is needed to sustain you at a weight that is not sub-healthy? Okay, I guess I can pause there.
Yeah. I think that I love having that slide up there. And I just want to say that when we first started having these conversations, 2.5 years ago, I definitely came from the viewpoint of very worried about exercise, and having had a lot of friends whose kids had just really awful experiences with exercise too soon, that sort of thing. So what's really important to me for everyone to know, and everything you say, and not that you don't do a great job explaining yourself, but sometimes when we had these initial conversations, like even what I envisioned you were saying and what you really were saying were very different. So that low and slow approach, when you're saying introducing exercise, and I'm imagining someone running 4 times a week, and you're talking about a 10-minute walk 3 times a week. And so that piece of it, I think, was really helpful for me to begin to understand the angle of why it might be okay to move sooner. And then I think another thing that was really impactful for me was listening to you, and then meeting some other people who might or did not have an issue reincorporating both movement and exercise at a later date. However, I have learned that there are a lot of people who, if they don't do it soon enough, become very fearful of it. And then that's actually a piece of recovery that isn't completed, because recovery should include the ability to engage in some things. And even if you realize, like, I'm never going to be a runner again because that was too tied up, you could still be a person who goes walking and then goes kayaking with your friends. And so kind of that idea of looking at all of this longitudinally, so the acute part, but then also over the scope of someone's life, how do we want this to come in and how do we want to manage it? And that we have actually a better angle on that if we start talking about it sooner. So that was just something that I want to contextualize for everyone. And this has been a huge part of my learning journey here, and also learning the value of dietitians and being able, once a kid's brain is where in a better place that the role dietitians can have in bringing all this pre-fuel, refuel, like all of that in, and test it and see what it's like, and then evaluate and those sorts of things. So.
And that, I appreciate that. That's actually also a good learning for me to make, and this is coming in some future slides, but always to make sure to give the context that we're talking about very low and slow, kind of graded, gradual reintroductions that could span over a year's time. This is not something that can or should happen quickly, right? And I think a lot about going back to kind of the motivation for movement. I think a lot about some of our even our high school runners that we've served in program who start out, with very adamant that they love running. Running is just part of who they are. But when you take weight loss off of the table, and that's a contingency for being able to return to running, is maintaining at a nice, livable, appropriate weight. Sometimes we get to the heart of it, that running really isn't enjoyable. They hate it. They don't want to participate in it at all. And then we can start to explore other avenues of movement that they do enjoy, whether it's like bike riding or gardening or walking or yoga or whatever the case may be. And that kind of goes back. It's not the running that's the red flag per se, but it was more of like the entanglement with eating and the compensatory nature of that relationship that was kind of like the red flag there. And that's true of any sport. You see it a lot in running, but
yeah. Maris, just come off mute and sort of you have a lot to say on this.
You see me nodding, so it's like, yes. I really agree with everything that you all are saying. And I think that intention piece is so important, Megan. And I know at the time that I developed an eating disorder, I was a swimmer and nobody talked to me about nutrition. I mean, I look back now, I'm like, I was horribly under eating and I didn't know it. My family didn't know it because it was so, like you said, Megan, normalized amongst that peer group of like young teenagers to skip breakfast or whatever. And, I think a lot about that. And I know at the time that my family was reintroducing movement and exercise, they kind of expected me to go back to swimming at first, but it became clear quickly that there was just so much entanglement, like you were saying, Megan. And I feel really lucky that, I think hindsight 2020, we maybe would have moved even slower than we did, but I do think I was lucky to find movement in the form of yoga, where I had teachers who were very clear about that intention piece. And they were like, what's also yoga? Taking rest and showing your body care and compassion. And I know often we aren't, shown movement in a way that has that framing. So there's a lot to consider for sure. But I think having that supportive community around it can be a really important element.
And you know this better than anyone, Maris, but there's a whole lot of literature supporting the inclusion of yoga or introduction of yoga throughout the course of eating disorder treatment. But I, even in working with, I worked with local university USD's athletes for a number of years, and they introduced yoga for all sports. So football, it's basketball, it's a D1 program, some excellent athletes there. And it was really cool to see how they responded to it. And also it just felt, I think, also like it gave them an avenue to be very compassionate to themselves in a way that like you just don't see that in the training that they were going through for football, for basketball, for soccer, and all these things. They really, really enjoyed it. It was really special. And we see kind of similar results in the eating disorder population who might be using exercise as a form of punishment.
Yeah. And also yoga is not a panacea. And I think we see that it's so dependent upon how you're exposed to it and how it's taught. And in the true, and I won't give a full lecture on yoga right now, not that I'm the most qualified person to do it anyway, but there's so many different elements of yoga, and just one tiny part of it's the movement. The rest of it is mindfulness and self-reflection and the philosophy. And so, I have also seen folks who go to yoga studios that, it can become something that's abused, just like any other form of movement, right? So I think it's something that requires a lot of thoughtfulness around it for sure.
Yeah, what comes to mind is, and I know I've enjoyed it. People love it, but I think of like the hot yoga or the Bikram or the core power studios here that are tons of fun, also fairly militant and somewhat rigid in the practice. And I'm by no means, Maris is our resident yoga expert, but it's interesting to see it take that shape when I assume kind of the roots were very different, or the intention was very different in the beginning. And yeah.
I just want to put in one last anecdote on that, like evaluating the motive thing. We had very early on, pretty much as soon as we started DBT and learning about mindfulness, was when my daughter was like, I want to swim. And, that was exercise. And at the time, again, it was a no exercise thing. And her eating disorder made, as they do, very compelling and heart wrenching arguments. The main one being like, everyone is all talking about DBT and mindfulness and flow activities, and swimming is my flow activity. And you people want me to recover, but you won't let me have my flow activity. And of course, I'm like, this makes sense. Oh my gosh.
Mhm.
So I advocated, sort of for the swimming. And so the teams, sort of came together, and we, together with the team, we presented to her, okay, we'll allow some swimming to begin. However, your mom is going to be on the deck of the pool anytime that you swim, just monitoring to make sure that it is a very slow flow swim and not any form of exercise. And that was the last time swimming was mentioned for a very long time.
Yeah.
So, clever move on the part of the team to like suss that out. So
It's
I
a
do
good
think it
fitness
would
test.
be, I think it might be helpful to get sort of everyone's perspective again to this question about someone who, had the eating disorder, is starting to recover, and picked up running sort of before weight restoration in the, which is still sort of in the eating disorder thing, and different perspectives, and sort of caveating this that we're not the treatment team, we don't know anything more than that comment about that. But I think it might be interesting for people to hear, sort of different perspectives on that. I don't know, do you want to go first, Megan, on what you might say to someone in that situation?
Yeah, yeah. I'm even this kind of drums up some. We've seen it so many times, as you mentioned, that you take weight loss off of the table and running loses its luster. Then I'm also thinking about an elite runner that I worked with for a very long time who really needed a higher level of care earlier on and delayed getting treatment because all she had heard from her providers was give up your sport, give up. And she was competing very successfully at her sport, even unfortunately when she was really suffering. And she didn't really want to hear that again. So it really delayed her getting care. So I kind of also think of folks who really do enjoy their sport and how important it is to really validate that and kind of help them find their way with, having that healthy relationship with their sport. Eventually she was able to find like a program that was a really good fit and is now still running. But should I go ahead and check the chat for?
Well, I think we're good. Well, I kind of
Let me know. Okay.
rounding things, yeah. So I'm gonna say, so like from a parenting perspective on that, I'd be super leery of
Yeah.
starting running without having weight restoration first. So
Oh, yes.
I don't know what is, sort of what your parameters are around that, but certainly would want to be making here to Quip. We really think that 2 to 3 pounds a week is achievable
Yes.
gain. And I think it's interesting, like, quick on the weight gain, low and slow on the exercise reintroduction, sort of thing for me. So in terms of running, I think like to even really answer this question, there would definitely have to be a lot of context about,
Yes.
how long is the, sort of what's the weight gain going? What's the food behavior? How often is the running? How long is the running? And want to put in, sort of a plug for, I've seen it work out both ways. I've seen people who are successfully able to do all of this all the way through and are fine. And I've seen people who everyone thought were successfully able to do it the whole time, and then they broke their leg or something like that and couldn't exercise at all for a period of time. And the eating disorder was like, so I think regardless of what choice you make with your team about the running at this point, because I think it's pretty hard in a person with a still active eating disorder
Yes.
to suss that out. I would absolutely have like, this week we're not running. What happens
Right.
if we say this week we're not running, kind of thing, and just like poking that bear and seeing sort of what reaction you get, because that tells you a lot. What would your take be, Maris?
I think you hit the nail on the head, JD, that I think a really important part of healing my relationship with movement and exercise was also getting really comfortable in my relationship with stillness. And when I was not comfortable with stillness, my relationship with movement was not where I needed it to be in order to sustain recovery. So I think you're right, Didi, that, kind of implementing those breaks and those moments to not run can be really helpful gauges to see the reaction and to see, at the end of the day, we don't want running or exercise to be your only skill in your toolbox. You need to have other things because there will be seasons of life where you can't run for whatever reason, or you can't practice, the physical practice of yoga for whatever reason. And you need to have other things that also help you be in a flow state, like you were saying, JD, or get through difficult days.
I love the flow state idea. And I think this is kind of anecdotal, but one thing that I've noticed is that folks who are holding really tightly to continuing to run upon entering treatment are the folks that we really wish for long periods of rest, right? Because they do need to build some other coping strategies. And we can get into some of the recommendations in a moment here, but I think the tolerance of rest is a really, really important marker for being able to advance someone even to low and slow forms of movement. So way before the running, even being able to do walking, hiking, biking, resistance training. They need to be able to tolerate some stillness, as you said.
Yeah. I really want to get to these slides, so I'm going to run through these questions real quick because I think
sure.
we're really going to want to know this. So, question about caffeine. So drinking a cup of coffee and then getting jittery and wanting to move. I'm personally kind of a proponent of not caffeine. If your kid's like under 18 and you're kind of calling the shots on that, caffeine to me seems like maybe not super helpful in the beginning of recovery. So, I think people have different opinions about it. Some people might, well, as long as they can continue to gain their weight, that's fine or whatever. My experience is that there's a lot of beliefs about caffeine and how caffeine affects your metabolism, things like that. So, although, and then again, I can make the case for one cup of coffee being sort of one cup of coffee, and also pour some heavy cream and some sugar in that one cup of coffee.
Yes. Yeah. If at all possible, what I would typically recommend is in any kind of adolescent population, it's hard, but try to limit to decaf or decaf type drinks, or it can be incorporated into their meal plan, so to speak, in terms of because I know that's something teenagers do, right? They go to Starbucks, but maybe at least throughout the course of treatment, encouraging like decaf drinks that are still fun, again, that are kind of part of the meal plan. That means with the inclusion of things that they enjoy in them. So like with cream and sugar, not so much just like black coffee. And caffeine is my general go-to would be like 1 cup a day following the meal. And that is contingent upon being able to complete the meal. So not skipping breakfast or eating half of breakfast and then getting the coffee, right? Being able to complete the meal, meet hydration needs, and then go right into the morning snack without any difficulty. So it's kind of truly like an extra or a condiment on top of the structured meals and snacks. It can be a really good carrot in that way. In terms of like the appetite suppressant effects, they're actually pretty short-lived, and caffeine ends up increasing the appetite as it wears off 5 or 6 hours later. So that's something that's interesting to know. I don't always share that with folks who are struggling, but sometimes I do, because it's interesting to think of, the withdrawal effects are always kind of the opposite of the intended effect of the drug, right? So the thought being it's an appetite suppressant, it makes me feel more alert, it picks up my mood, but later on in the day, it actually doesn't do that. So
next one is a comment. I'm going to read it just because people get the recording, but they don't get the chat. So FBT therapist let kid be on school sports team, and it turned out to be great. It was late in phase 1.5, which I love. You know how I love phase 1.5. We don't need black and white thinking here. Job not fully done, but I think it was helpful for overall psychology. And I would say that is something that my mind has been open to in working with different families at Equip, when you can suss out the motivation that sometimes it is absolutely the right call to make.
Yeah. Yes.
Question, Maris, interesting to hear your family thought you would go back to swimming and it wasn't right for you, and my daughter's story as well. Very helpful. Do you think it's not appropriate to use going back to swim as a motivational carrot because it might not be appropriate in the end? I think that's a really awesome, nuanced question.
I've got a slide on that too. I think it might even be next.
Okay.
Yeah,
Maris.
Oh, sorry. I was talking over you. I didn't hear what you said.
So what this whole idea of swimming as a carrot, I'll just say, like, my gut would be that I think it's actually okay as long as everyone's open to the possibility that once you get there, you might recalibrate.
Mm-hmm.
Yeah. I think that's accurate, JD, where, you can use it as like a life worth living goal of like, I'd like to return to the activities and the community that I was a part of before the eating disorder. And if I get there and I don't want to do it anymore, I can find another community or activity to be a part of. I think it's also being mindful about the way you frame it. So it's not unintentionally reinforcing ideas around, in order to deserve eating, you have to exercise. But I think there are ways to thread that needle.
And also, Maris, to piggyback on that point, even the idea that you have to do something to be worthwhile. And I think that's a really common thing. You mentioned struggle with stillness. Certainly that was something that we dealt with. There's a question in the Q&A about someone who's struggling immensely to tolerate rest. And I think there are very often, for a lot of folks, this productivity as worth thing gets tied up. So like that was a huge thing for my daughter. And I will say that one of the beautiful parts of the exercise coming off the table in the way that we walked through it was that art became then took a much bigger place in her life, and was more into that stillness and being alone, sort of being ability to tolerate sort of being alone. But we'll leave the rest of Megan for your slide. Deborah, the flow state is basically like in mindfulness. You sort of want to be able to get into a state of where you're just sort of not really thinking. It's something sort of meditative that you're just kind of going through. That's a mind clearing activity. So, swimming, yoga are common ones. People do like coloring books because you're not drawing. Drawing takes more intention. Coloring books, so you're kind of just wanting to get into that state where you're, quieting your mind down is really the goal. Another comment, my daughter dropped sport before eating disorder, picked it up at the worst, and today I celebrate that she acknowledges the need to walk to the store for food as a young adult outside my home doing her thing. Yeah. Absolutely vital and important. This topic is so helpful. My daughter was in PHP and virtual IOP and just discharged to resume back to activities, track. As she transitioned between dietitians into outpatient, the two dietitians had different guidance, important thing to discuss, on the importance of refueling her body, adding an extra snack a day, which was really confusing. Do you recommend the refueling and adding the extra snack, or just sticking to the 3 meals, 3 snacks? She had just checked 1 month checkup after discharging, starting track, and had dropped 4 pounds, but is still within target weight. Should I be concerned? Keep an eye on. There's a lot to unpack in there, so I'm going to bring it. First of all, I love this question. Do you recommend keep the 3 meals and 3 snacks and have more, or do you recommend a pre-fuel and a refuel that are kind of tied specific to the exercise?
Those are two totally different strategies that will pop up a lot with no real clear winner. One thing I really like about having kind of a baseline meal plan, if you will, 3 meals, 3 snacks, and then having a refuel, is it does get someone in that intentional habit of meeting the demands of training. What I don't like about it is it feels a little bit transactional at times. I've used it and it's worked okay, but it's also kind of like that. It's the earning of calories. Then again, we do have to meet the demands of training, right? But if someone's on a 3 meal, 3 snack plan, usually in terms of timing of nutrients and getting the needs met, you can do that by just fortifying one of the snacks to meet the needs or meet the demands of training. And it usually does come back to the bottom line is, are we feeding this kiddo enough to be able to sustain, a healthy, livable weight and growth and development, regardless of the number of meals and snacks, with the addition of training? If not, I would change it up so that we're there. Typically, when someone starts to fall down in terms of weight, especially if they're not able to recover pretty quickly, like within the week, we start to reduce the training and we kind of move back a step, if you will, not as a punishment, but as a means of keeping this person safe and sending a message to the eating disorder that regardless of how it happened, we have to address it, swiftly.
I love that. And I love the word fortifying. I really do love the word fortifying in that.
Yeah.
Well.
So you might have 4 meals and 2 snacks essentially. And that's the job of an athlete or an active person, to meet the demands of training. And just to, kind of, JD, like you mentioned, that I really want to stress that we're not talking about going from rest to running in the course of a week, or rest to any sport over the course of the week. When someone starts in treatment, there is a period of abstinence, if you will. And that's also what we do almost across the board. Every single patient that starts with Equip is asked to rest, while they undergo medical clearance and then team clearance, which just means we're looking at some of, maybe they're medically stable, but behaviorally, is it a good idea to reintroduce some movement after the first week? That's something that we have a lot of conversations about. And moving through the stages means being generally compliant or able to meet the asks of the treatment team as far as 3 meals, 3 snacks, gaining 2 to 3 pounds a week, a decrease in other behaviors, being honest about sharing the urges or the struggles as they come up, and a willingness to do the low and slow here. And what we mean by that is maybe week 3, week 4, week 5, whenever it is that activity is reintroduced, like stretching, 10 to 20-minute walks, maybe incorporating some like hill work, not seeking it out, but maybe your neighborhood is hilly and you can't avoid it. And perhaps that's fine as long as someone has kind of been cleared for, some moderate intensity walks. And an important thing here on behalf of the family to know when you're reintroducing is the modeling really helps, meaning you paying attention to cues. If you're injured, not going on your morning walks and maybe having your kid witness that if they know that your foot's hurting or you have like plantar fasciitis and they know it's painful for you. Even though the movement is important, so is the rest and so is the healing. And it's really good for them to see that. It's also nice to know that we're disentangling this from food. So pizza night isn't immediately followed by an hour-long walk, but nights that we have a salad, nobody needs to move afterward, right? So just trying to be really mindful of how those two things can and should be divorced as much as possible.
Yeah, because you really are fighting the messages you get from society.
Yeah,
And I think too, and even though we, sort of didn't do the formal exercise stuff, one of the things we did at the end of treatment, because we weren't going to do the exercise, and my husband's a runner, and the gym was part of our lives and things like that. We got a slack line for our backyard, which was,
fun.
it's very hard to do. If you've never done a slack line, it's very hard to do.
Harry granola. I didn't know you had it in you. That's great.
Oh, I was up for about 1 second. There's a picture on Instagram, and that was it. I'm like, my work here is done. I got the gram. I'm out. But it was fun because one of the good things about it was none of us could do it. We were all at it.
Learning
so
together.
We're still in the yard and we're doing, it's some form of movement, but it was just fun. It was just really fun. So I think that was helpful. And I think this slide really feeds into another question that I'm just going to read out loud. And Maris, while maybe you can handle this question. Any online yoga or Pilates that you would recommend that is not filled with diet talk?
That's a tough one. I know Jessamine Stanley is really well known in the yoga space for having weight inclusive and size inclusive practices. Eat, Breathe, Thrive is a nonprofit that's completely centered around creating yoga spaces that are accessible to folks in recovery. It was founded and all the programming is designed by someone who's in recovery themselves. I might do some more thinking, JD, and send you some more recommendations, but those are some people off the top of my head.
And actually what we'll do on that question, if Maris, we'll get with Kira and we'll just pop a couple into that recommendation. Thanks for that. That's actually a really good thing for us to think about including. So I'm going to read this question because I think it feeds into this. My daughter, 23, has never really developed any other ways to manage her clinical exercise besides the calming effect of her sport. She's pretty desperate to keep activity to help her manage her anxiety since she doesn't feel she has other options. How do you introduce them to something new that will help them when they are very resistant to change?
Yeah. This is a really good question. And I think of, so let's say someone's entering in a program, I think of that as just critical for that person to kind of be able to learn to tolerate stillness, rest, and also learning to use other coping strategies. So one of the fears that comes up a lot when folks enter treatment, and especially if their kid is training or a competitive athlete, or as you said, just kind of really wed to their sport or activity, is this fear that if I pull them out of their sport, they'll get worse. And chances are they will feel worse. Absolutely. That's also not sustainable, right? Because at some point, God forbid, but it will likely happen, this person will get injured and not be able to engage in their activity and perhaps won't be able to tolerate the rest and the recovery that's needed to be able to heal from that injury. That's especially likely in someone that's restricting or restraining their intake as well. So I think, what we're usually looking for to move activity forward is for someone to be able to engage with some other coping strategies that they're learning through, being in treatment, and that they're not routinely like exceeding the recommendations. So we maybe we say 30 minutes, but you notice that they're gone for 45. It's always kind of pushed to the max. They're not listening to their body. They're not very responsive to bodily cues, just generally speaking. These are red flags for us. And so, while I don't doubt that a person is greatly enjoying many aspects of their sport, I guess my fear would be that it isn't sustainable. It's not safe. It's not going to translate well when they do have seasons of really needing and having to tolerate rest.
And that was actually, you've kind of answered a question before it was even answered, because somebody who had been through treatment, allowed to return to sport, and then the injury, and then that's, sort of really feels like a setback. And I think, how would we help her through this? I think one of the things, and I'll kind of answer this as a parent, is that it really turns out that our job is sort of not to save our kids from any of this. It is actually to help them walk through and sometimes feel all those complicated emotions around that, and figure out in real time, how will I manage, without that. And so I think that's a really important piece of it. And then there's the question about, how do you introduce them to something new when they're very resistant to change?
Yeah.
Maris, this is a good one for you to sort of weigh in on.
Sure. I mean, I think what comes to mind for me here is that we know eating disorders often really thrive on rigidity. And so I think if we think about ways to challenge the eating disorder, I would imagine that having more flexibility and the ability to try different forms of movement could be really helpful there. And I know for me, my eating disorder really liked rigidity around movement because there were a lot of requirements. It had to be this level of intensity, and there had to be this many calories burned, and there had to be this many steps, whatever it was. And so I think it was important for me in healing my relationship with movement to break all of those rules. And that meant trying many different forms of movement. And so I would say it can be complex on how to support someone else in navigating that difficulty. But I know for me, very similar to an FBT structure, but just with movement, my parents had to make some contingencies, and they had to, in some ways usher me along in that journey in ways that I wouldn't have necessarily chosen for myself. So, I think I saw there was a question here as well about, what are some ways to learn how to tolerate stillness? And I imagine it would be similar for tolerating the distress of changing, your movement strategies. But I think a lot of the common skills you use in recovery are helpful here. Things like distraction and self-soothing and all the other coping skills that one might utilize to get through hard meals or hard days could probably be helpful in navigating the distress of leaving or changing different forms of movement.
And one put a pin in that, the question was about a 23-year-old, and that's really going to depend on a lot of variables in terms of 23-year-olds could be many different things. They could be completely financially independent, self-supporting adults who you're just sort of like consulting or advising with from afar. And then they could be people in your home that you're financially supporting. And those are really two different answers on this. I want to be mindful of everyone's time because it's 5:30, and Megan, I know it goes so fast, doesn't it? You have little kids. Do you need to pop off right now, or do you have 5 minutes to wrap things up?
I have 5 minutes to wrap up. They're busying themselves somehow. So when the doors flies open, you'll know I have to make like a hasty exit. But I think too about in terms of how to tolerate the stillness in a situation like you described with a kiddo that maybe has a little bit of a perhaps this, or let's say is overtraining and underfeeding. We know that an underfed brain is an anxious brain. So I also think of the impossibility of being able to teach someone or give them the skills to tolerate rest while they're still underfed and overtraining. That's hard. And I also agree with JD that it might not be something that the parents can or should do to kind of connect them with or suggest activities that are going to like resonate with them. It might not be even something that's on her radar right now or that she can access while she's still engaging in running, let's say. I think you said it was running. But perhaps if she's open to having some support around her and a team, they can kind of start to explore, ways in which she can, activities that she might enjoy or find some joy in. And I think she'll especially be able to maybe connect with those, connect with different activities or different ideas when she's kind of in a place where she has to tolerate that rest, right? And isn't engaging.
And so it can be that piece where the nutrition has to precede. The nutrition
has to come first.
The ability to talk about that. And I think thinking about it in terms, I'm trying, just like racking my brain, how did my daughter become a person who didn't really tolerate stillness very well to one who does very, very well? And also as a person who, not my favorite thing sort of either, in a different way. But I think one thing is tolerating it in really small doses to start up with. So,
Mhm.
it doesn't mean that you have to spend, an entire half a day doing nothing. You could start with spending 15 minutes doing nothing and then build up and keep adding on that.
And
I'm gonna read
also,
Go ahead.
I just want to say also that sometimes we can make these choices intentionally to start with small, moments of stillness. And sometimes these choices are made for us because someone gets injured, right? And is forced into a situation where they can't engage in compulsive activity for long periods of time. And sometimes that's where people unfortunately make that shift, right? Because they have to.
Yeah.
You want to
Yeah.
avoid that.
Read a couple of chats because I think this is a really good one that alludes to what you're seeing. We've even had fairly gentle walks become compulsive over time, like the concept of being able to tolerate rest. We found allowing exercise 2 to 3 times per week a better approach than something smaller every day, as that seemed to reinforce rigidity and thinking. I think that's a
Mhm.
phenomenal
I
insight.
like it. Yep.
hmm And then a comment I want to read out. I'm the mom of an adult in recovery who was a D1 varsity runner. I'm a firm believer that there absolutely must be a clean break with exercise for at least a period of time and an acceptance that the person may or may not be able to go back to the sport. Some can, some can't. My daughter watched teammates go to a treatment program for athletes that allowed exercise in the program for athletes. My daughter watched teammates who went there cycle in and out of treatment and participation with the team. She also knows currently competitive athletes who are successful and still quite ill. Mine isn't one who's been able to go back to a competitive level, and that's okay. She has been able to stay in recovery and start a career in advanced education, which absolutely could not have happened for us if sport had stayed. We do walks and fun one-time activities now. I think that's such
Yeah.
an important message for people to hear, and particularly in that I say that all the time. We don't know. We don't know when we start who can go back and who cannot.
Yes. Yeah.
Uh, and of course, my team has the complete opposite of this. Stay still too long, getting edema, trying to get her to move is like pulling teeth. And that is that space sometimes. So, Megan, I'm going to let you run through the rest of the slides that you want to make sure that we get to today in the recording, and then we'll get those out to folks. And I'll also let folks know you can get how to get the recordings and things. We'll
Sure. Yeah, I'll go really quickly. I think I only have 2 left, but the one thing that I want to emphasize, if you're at that point, that juncture in treatment where you're starting to think about or dabble with reintroduction of activity, expect a lot of adjustments, and I would set those expectations with the kiddo too. Several adjustments as we all figure out how that landscape changes when someone gets stronger, increases their training volume, becomes more active. We're also trying to grapple with the fact, again, that they're in that refeeding phase and that the needs are just super high. It's not going to make sense on paper. We just, have to feed really aggressively. So expect several adjustments as we all kind of figure out how to keep this person at a stable, livable, healthy, sustainable weight, or in an increasing pattern of weight, if that's what's needed. Last slide. These are just some of the concerns I think that came up in the chat that I want to highlight as very, very normal and very real. Again, that thought that if we restrict the kid from exercise, they're going to decline really quickly. That might happen, and I will argue that it will happen anyway at some point if we don't address that compulsive exercise early on and really kind of do our best to implement a short period of rest or abstinence. Another concern is that it'll affect the scholarship opportunities. We've seen this a lot. Kid needs to stay in sport to be able to potentially take advantage of scholarship opportunities in college, or maybe even they're on track to participate in Olympics or what have you, become professional athletes. Yes, that is super important. And if they don't address this now, I think their chances of being a successful athlete are greatly diminished, because once they re-injure, once they injure, they're more likely to re-injure and remain ill, right? So we want to give them the best chance at success. Other very real concerns are that adding exercise will trigger relapse. We've heard some stories where that was absolutely the case. Weight loss is a common concern. I will say that exercise is not, most forms of exercise are not very effective in terms of bringing about weight loss. It's the it's the restriction of calories that has been responsible for most of that for folks, especially with eating disorders. So it's not something that we can't overcome by adding in refuels or making sure the demands of training are met. I think I'll stop there because I think that we covered some of these other concepts through the course of our discussion, and I know I've kind of run over time. Well, here's some tips for family that I think we've also covered. It can be a great motivator. It can be a fantastic carrot if the kid loves their sport to engage in treatment and get well. So that's something to consider, but you have to kind of think of the entire landscape of someone's struggles. And yeah, it's usually a lengthy discussion.
Yeah, absolutely. Well, thank you so much. And I'm sure we'll do this again. There are so many questions and this is a conversation that can go on forever. And again, just I appreciate everything I've learned from both of you about this, and so glad we can have other people in and like just have this conversation in a flexible way and not in a black and white way. And really appreciative of the work we're able to do with this. So thanks everyone for joining us. I'll make sure that we get a couple yoga links into that email and figure out how to get everyone past recordings who needs them. So thanks so much, and we will see people next week. We'll
Thank you. Yeah, thanks JD and Maris and everyone who joined. I appreciate this so much. Thank you.
All right.